Thank you, John. And I'm gonna share my screen.
Could you please introduce yourself, Nourou, and what you do and where you work, etc.?
Okay, I am Nourou Bankole, and I am resident in neurosurgery. I am in Rabat, Morocco, WFNS Reference Center Training of African Neurosurgeon. I am in 3rd years of my training course.
Very good.
And, nice to meet you, and thanks all to come to support our neuroanatomy, school anatomy lecture today. Thank you, everyone. Do you hear me?
Yes, we can see it well. We can hear you well.
Okay, so now I share my screen. I don't know if you see that.
Yes, it's perfect. It's perfect.
Okay, so I will go ahead and start my presentation.
Yes, please.
Okay, thank you. So today I will talk about hydrocephalus. I will use this plan introduction. I will talk about anatomy, physiology, and background, physiopathology and clinical diagnosis, paraclinical diagnosis, etiology of hydrocephalus, and the management. And I'm gonna talk after about prognosis and conclude it. The term of hydrocephalus is derived from 2 words. Hydro meaning water, and cephalus referring to the head. Hydrocephalus is a condition in which excess of cerebrospinal fluid builds up within the ventricles, fluid contain cavity of the brain, and may increase pressure within the head. Although hydrocephalus is often described as water on the brain, the water is actually CSF, a clear fluid surrounding the brain and the spinal cord. Hydrocephalus can occur at any age, but it is most common in infants and adult age 60 and older. According to the National Institute of Neurological Disorder and Stroke, hydrocephalus is believed to affect approximately 1 in every 500 children. The majority of these cases are often diagnosed before birth, at the time of delivery, or in early childhood. We have clinical form in infant, children, younger adults, and older adults. I will go quickly about anatomy because Dylan was done this topic last Friday. So from an anatomical point of view, the CSF is divided into 2 main systems, the ventricular systems, who contain the lateral ventricle, the 3rd ventricle. They communicated with each other, and we have the extraventricular system composed of arachnoid space, pericerebral, and perimedullary space. The hydrodynamic of CSF is explained by 3 phenomena: secretion, circulation, and resorption. About the ventricular system, we have 4 ventricles lodged inside the brain, are described, they communicated with the subarachnoid space and the arachnoid system of the base skull. They are lined by a particular epithelium called ependyma. So we have 2 lateral ventricles. We have 2 lateral ventricles, semicircle shaped cavities, open forward around the basal ganglia. Each cerebral hemisphere has a lateral ventricle. They are described 3 horns. We have 3 horns: frontal horns, temporal horns, and occipital horns. The junction of the 3 horns is the ventricular junction or atrium. Both ventricles are separated by a septum called the septum pellucidum. The lateral ventricles have a capacity of 10 milliliters and communicated with the third ventricle by the Monroe holes. It is the interventricular foramen, which measures 8 millimeters in diameter. The third ventricle has a quadrangular shaft dragging the diencephal, measuring 25 long and whose walls are 5 millimeters apart. It communicated with the fourth ventricle via a filiform canal running through the midbrain, measure 15 millimeters long and 2 millimeters wide. These holes means the aqueduct of Sylvius. You can see here the aqueduct of Sylvius. This it is the third ventricle, and this it is the fourth ventricle, and here you have the two lateral ventricles. The fourth ventricle an odd cavity located between the brainstem forward and the cerebellum behind. It has a lozenge shape, like you can see here. That's a lozenge shape, like that, like this here. It's communicated with basal cisterns and subarachnoid space via two foramens, the Luschka foramen holes at the lateral angle and the Magendie hole measuring 4 mm to 6 mm located at the lower part of the fourth ventricles. These anatomic features are found during intraventricular video endoscopic procedure. I will go ahead about extraventricular system. We will have the subarachnoid space, who is limited by the arachnoid and the pia mater. The pia mater closely intimate contact with the surface of the cerebral cortex as well as the spinal cord. At the base level, we find the arachnoid tank, whose main ones are the chiasmatic cistern, the basal cistern, the ambient cistern, and the cisterno-medullary cistern of the large cistern. You can see here the large cistern, the ambient cistern, and the fourth ventricle here. The physiology of CSF rests on three phenomena, like I was told in my introduction. It is the secretion of CSF, the resorption of CSF, and the circulation of CSF. When we have disturbance of one or more of these factors, cause hydrocephalus. So, about secretion of CSF at the level of the CSF was secreted at the level of the choroid plexus, which are vascular structures located in the lateral cerebral ventricles. 150 milliliters total on encephal and spinal cord will secrete between 4,150 and 7,150 milliliters per 24 hours. The CSF is renewed 4 to 5 times per day. About circulation of CSF, we have the CSF come from plexus choroid in lateral ventricle and come to the third ventricle pathway Monroe holes, and then Sylvius aqueduct, and then fourth ventricle, and after we can go to the subarachnoid space and cisterns through pathway Magendie and Luschka holes. The brain, spinal cord, and nerve roots are surrounded by the CSF. CSF resorption at the level of the arachnoid villi, which are invaginated in the superior longitudinal sinus. CSF pressure, intracanal pressure, we can have 10 to 50 millimeter mercury on the child and 50 to 20 millimeter of mercury in adults. If CSF volume increase, we can have increased intracranial pressure. What about physiopathology? Acute hydrocephalus revealed by increased hypertension, intracranial pressure syndrome can be explained by several mechanisms, like obstacle to the circulation of CSF at the origin of an obstructive or non-communicating hydrocephalus, dilating a part of the ventricular cavity, Resorption disorder causing obstructive or non-communicating hydrocephalus dilating part of the ventricle and sometimes the subarachnoid space. We can have hypersecretion of CSF, who is rare. Hydrocephalus is often categorized for age group as either congenital or normal pressure hydrocephalus. Congenital hydrocephalus refer to conditions that are caused by conditions existing at birth. Primary symptoms include headache, nausea, vomiting, and drowsiness. Normal pressure hydrocephalus NPH, it is the accumulation of cerebrospinal fluid that causes the ventricle in the brain to become enlarged with little or no increase in pressure. Adult onset NPH mainly occurs in adult age 60 and older. Sometimes patients with NPH often get misdiagnosed with Alzheimer's disease or dementia as some of symptoms mimicking these two conditions. Hydrocephalus are communicating and non-communicating. If the cerebrospinal fluid flows freely throughout the brain's ventricular system and the subarachnoid space, it is referred to as communicating hydrocephalus. If there is a physical blockage, such as a tumor somewhere in that system, it's called non-communicating hydrocephalus. I will go ahead about clinical diagnosis, and I will talk about different forms of hydrocephalus. We have infant forms, who is different from the adult form. The child cannot say that is hurt because it is child. The sutures are not made yet. Increased head circumference, like macrocephaly, can be occur. Anterior fontanel bulge, suture disjunction, cephalic cutaneous thinning, and hydrocephalus therefore increased intracranial pressure with result in oculomotor disorder like strabismus, a decrease in the visual acuity of the child, and like you can see in this picture, appearance ears of the setting sun. We can have like a symptom like anorexia, vomiting, apathy, irritability, and disturbance of consciousness and the focal neurological deficit. That is about infant forms, symptoms of hydrocephalus. About children forms, we can have abnormal enlargement of baby's head. We can have headache, nausea, vomiting, fever, blurred or double vision, unstable balance, and irritability and sleepiness. Delayed progress in walking or talking, and poor coordination, change in personality, inability to concentrate, loss of sensory motor function. We can have seizure or anorexia. Older children may experience difficulty in remaining awake or waking up. If the hydrocephalus is slow and long-standing, some children can have delay in their developmental milestones or poor learning in school. About young and middle-aged adult form, we can have just headache, difficulty in remaining awake or waking up, loss of coordination or balance, bladder control problems, and impaired vision and cognitive skills that may affect job performance and personal skills. About older adult form, like you can say in normal pressure hydrocephalus, we talk about Hakim and Adams triad. You can have loss of coordination of balance, ataxia, abasie, you can shuffling gait, memory loss, and headache, and bladder control problems. I will go ahead about paraclinical diagnosis. Transfontanelar ultrasonography is the first line examination in an infant suspected of hydrocephalus in front of macrocranium. You can see here ultrasound transfontanelar posterior coronal cup passing through the arm, occipital lateral ventricle like hydrocephalus here. CT scan, we acknowledge an increase in the size of the ventricles, ventricular hydrocephalus, who showed here the dilatation of third ventricles and two lateral ventricles with an almost normal size of the fourth ventricle. So it is tetraventricular hydrocephalus and disappearance of cortical transependymal resorption. MRI help to specify the etiology. Like you can see here in this MRI, T2 sequence, fluid attenuated inversion recovery, and sequence T1, gadolinium, show triventricular. You can see here the occipital arms of lateral ventricle who is dilated, and third ventricle dilated, and this expansive process was developed in the posterior part of the third ventricle, who is the cause of this triventricular hydrocephalus. Another case about hydrocephalus by hypersecretion of CSF secondary to a papilloma of plexus choroid with important dilatation of tanks from the base. I will talk about etiology, the common cause of congenital hydrocephalus and common cause of acute hydrocephalus, like secondary cause. So you can have malformation of the base of the skull, of the ventricular system, like malformation Dundee-Walker, malformation of Chiari type 2, agenesis and obstruction of the intraventricular foramina, and common cause of acute hydrocephalus secondary to a brain tumor, in particular the tumor of the posterior cerebral fossa or cerebellum, to a cerebral meningeal infection like abscess and meningitis. We can have hemorrhage, the blood is too viscous and blocks the passage of the CSF, like subarachnoid hemorrhage when we have aneurysm ruptured. You can have intraventricular and intracerebral hematoma. The common cause of congenital hydrocephalus, like aqueductal stenosis, the most common cause of congenital hydrocephalus is an obstruction called aqueductal stenosis. This occurs when the long, narrow passageway between the third ventricle and fourth ventricle is narrowed or blocked, perhaps because of infection, hemorrhage, or a tumor or malformation. Fluid accumulates upstream from the obstruction, producing this hydrocephalus. Like you can see in this case, stenosis. Here, there is no passage, stenosis aqueduct, and we see dilatation of ventricle apart. Common cause of congenital hydrocephalus, like neural tube defect. Another common cause, an open where the spinal cord is exposed at birth and is often leaking CSF is called a myelomeningocele and is often referred to as spina bifida. This kind of neural tube defect usually leads to the Chiari-2 malformation, which cause part of the cerebellum and the fourth ventricle to push downward through the opening at the base of the skull into the spinal cord area, blocking CSF flow out of the fourth ventricle and causing hydrocephalus. You can see this myelomeningocele who causing about this enlarged ventricle. We can have arachnoid cyst who is congenital hydrocephalus and can also be caused, which may occur anywhere in the brain. In children, there is often located at the back of the brain, posterior fossa, like in these cases. And in the area of the third ventricle, these cysts are filled with CSF and lined with arachnoid membrane, one of the three meningeal coverings. Some arachnoid cysts are self-contained, while others are connected with the ventricle of the subarachnoid space. So the fluid trapped by the cyst may block the CSF pathway and causing hydrocephalus congenital. Dandy-Walker syndrome, another cause of congenital hydrocephalus, the fourth ventricle here becomes enlarged because its outlets are partly or completely closed and part of cerebellum fails to develop. Like you see here, agenesis, cerebellum agenesis. Dandy-Walker syndrome may also be associated with abnormal development in other parts of the brain and sometimes leads to acortical stenosis. In some instances, two shunts are placed in the child's ventricles, one in the lateral ventricle and another in the fourth ventricle to manage this hydrocephalus. We can have Chiari malformation. There are two types of Chiari malformation. Both types occur in the bottom of the brain stem where the brain and the spinal cord join. The lowest portion of the brain is displaced and is lower than normal, pushing down into the spinal column. Common cause of acute hydrocephalus is the intraventricular hemorrhage. An intraventricular hemorrhage, which most frequently affect premature newborns, may cause an acute from hydrocephalus. When small blood vessels alongside the ventricular lining rupture, blood may block or scare the ventricle or plug the arachnoid villi, which allow CSF to be absorbed. When the CSF can't be absorbed, hydrocephalus results. We can have common cause of acute hydrocephalus like meningitis. Meningitis is an inflammation of the membrane of the brain and spinal cord caused by a bacterial or less frequently viral infection. Meningitis can scar the delicate membrane called meninge that line the CSF pathway. I can see here this meningitis cause this quadriventricular hydrocephalus. A cure of hydrocephalus may develop if this scarring obstructs the flow of CSF as it passes through the narrow ventricles or over the surface of the brain in subarachnoid space. We can have a head injury who can damage the brain tissue, nerves, or blood vessel. Blood from ruptured vessel may enter the CSF pathway, causing inflammation, and we can have seeds of CSF absorption might then be blocked by scarred membrane meninge or by blood cells. The CSF flow is restricted and we will have hydrocephalus development. We can have brain tumor. In children, brain tumor most commonly occur in the back of the brain, which is referred to as the posterior fossa. As the tumor grows, it may fill or compress the fourth ventricle, blocking the flow of CSF and causing hydrocephalus. A tumor somewhere else in the brain might also block or compress the ventricle system like here. I will go ahead about the management. What is the goals about the management? The goal is to restore the circulation of the CSF and derivation of this one to treat and after to treat the cause of this hydrocephalus. In emergency, in emergency, we can't wait. We have to do something. So we can go to external ventricular lead, soft kit implanted in one, a soft catheter implanted in one of the two lateral ventricles in the frontal horn, through the skull, and the cerebral parenchyma connected to a pocket by a tubing system. Flow depending on the position of the pocket relative to the ventricle, transient device, but we can have higher infection risk. So you have to pause and cure with great asepsis. And the indication is in hydrocephalus, in hemorrhagic context, or in infection context. So you can see here this dispositif, this device, external ventricular drain, this column, and this drainer bag for CSF. Outside the emergency, we have to perform valve of diversion, compound device, superior catheter, support catheter, in the ventricular system or ventricular junction, connected to a valve, placed under the skin, which regulates the flow rate of the liquid. The valve is connected to a lower catheter, which is tunneled under the skin. The lower catheter can be implanted in heart chamber, like right aorta, and through the jugular veins. We can call cardiac ventricular bypass, or in the peritoneal cavity, ventricular peritoneal diversion. The complication and risk of bypass valve, it is an obstruction of this catheter, of the catheter ventricular, of the catheter in peritoneal. We can have hyperdrainage, and occur subdural hematoma, or infection, local cutaneous, meningitis, peritonitis, and endocarditis. You can have hemorrhage if you sting catheter in the brain. Other treatment nowadays is with endoscopy surgery. It is the ventriculocysternostomy. The aim is to recreate normal CSF circulation by windowing the flower of the third ventricles. Only for certain types of hydrocephalus, like obstructive hydrocephalus. Only for obstructive hydrocephalus, we can perform VCS, ventriculocysternostomy. And this technique gives another route of circulation to CSF. A hole is made with a balloon in the membrane of the third ventricles. The advantage of ventriculocysternostomy, you don't need valve installation, less important infection risk, but we can have complications like intraventricular hemorrhage, vascular wound in basilar trunk, but it is rare. We can have obstruction of the stomach orifice, so the hole is closed, and it is necessary to proceed again. I will talk about prognosis. The prognosis for hydrocephalus depends on the cause, the extent of symptom, and the timeliness of diagnosis and treatment. It is important, the time of diagnosis, the cause, and the extent of symptom. Some patients show a dramatic improvement with treatment, while others do not. In some instances of NPH, normal pressure hydrocephalus, dementia can be resolved by shunt placement. Other symptoms, such as headache, may disappear almost immediately if the symptoms are related to elevated pressure. And in general, the earlier hydrocephalus is diagnosed, the better the chance for successful treatment. The longer the symptom has been present, the less likely it is that treatment will be successful. Prognosis, shunt malfunction or failure may occur. the valve can become clogged or the pressure in the shunt may not match the need of the patient, requiring additional surgery. In the event of an infection, antibiotic therapy may be needed and likely temporary removal of the shunt and replacement by a drain until the infection clear. And after, the shunt can then be reimplanted. When a shunt malfunction, a surgery is often needed to replace the blocked or malfunction portion of the system of the shunt system. Fortunately, most complications can be dealt with successfully, but we can have death in acute hydrocephalus without emergency management. So, in my conclusion, hydrocephalus are diverse in their physiopathology, their etiology, their clinical translation, as well as in their prognosis. Hydrocephalus at normal pressure is today the subject of all questions. Good collaboration between neurologists, neuropediatricians, and neurosurgeons is essential for better management. And we have always to think about acute hydrocephalus. Thank you for your attention.
Thank you very much, Nourou. Let's get you off the screen share there. So just click on the leave screen share.
Thank you, John.
Yeah, I'll do it. I'll do it. Okay, no problem. There we go. I got to stop my screen share. Yeah, excellent. I'm sure students as well as attendings like to get refreshed about that. Okay, let's just introduce a couple of members that came late. Okay, Nourou. Nitin, could you please introduce yourself to Nourou and myself and all the rest? Go ahead, Nitin.
Hello. Hello, myself Nitin. I'm from India, South India.
Okay, welcome.
Thank you. Thank you.
Welcome. And let's see who else still in. Everyone met him. Anybody else that hasn't been? Hawaii, you want to try again? H-U-A-W-E-I. That's all the name I've got to introduce you. I'm unmuting you. Can you take? Okay, go ahead. Go ahead. Please introduce yourself. Can you hear me okay? Well, maybe not. Okay. Okay, there's Hugues. Hugues Christian. Could you please introduce yourself? I don't think we've met you yet.
Okay, thank you, sir.
Could you please introduce yourself?
Yeah, my name is Christian. I'm a resident at the hospital of Ibn Sina in Rabat.
So, John, I will present you Hughes. It is a young resident who just started his residence in the same center like me. He is come from Benin and now he is in Rabat Center WFNS training. And Huawei P9 is Dr. Jose who comes from Congo. He's in my center here in Rabat, and he's in first year his residence course.
Yeah, it's a fairly small community of neurosurgeons in Africa, right?
Yes.
I guess if you go to the main conferences, you meet a lot of people, right?
Yes, it is.
Yeah, that's great. That's great. Hope we can bring it closer using this tech. But we'll see.
Hello.
Hello, go ahead.
I wanted to ask a question to Dr. Nourou.
Okay.
Yes, go ahead.
I read about the cauterization of the choroid plexus in the treatment of hydrocephalus. I just wanted to ask, I didn't see it in your presentation. So when can you do that? When do you think it is appropriate, or which type of hydrocephalus is appropriate to do the cauterization of the plexus choroid, the choroid plexus?
Yes. Nowadays, I know that with endoscopic procedure, sometimes when we finish to open, we done the stomy, we can cauterize the plexus choroid. That is, give a good outcome and prevent recurrence of hydrocephalus. So that is to prevent the acute recurrence of hydrocephalus. Sometimes we perform cauterize plexus choroid.
Oui.
It is to prevent the recurrence.
Yes, Dr. John, I have some comments.
Go ahead.
Thank you.
Yeah,
You're welcome, and thank you for your brilliant presentation about vascularization of brain. Thank you, Natalie.
Thank you, Dr.
Go ahead, Dr. Kabulo. Are you there still?
Yeah, it's okay. Thank you, Dr. Nourou, for your presentation. I have a few comments on your presentation. Like, I think this is like we are doing the basic sciences, since we have also medical students among us. So, like, when you are talking about hydrocephalus, you are talking about physiology of CSF production. It was also good to mention few small things like how it is produced, in how many percent in lateral ventricles, in fourth ventricles, in the spinal cord, how much CSF is produced there. And at the beginning, you mentioned that there are two types, congenital and normal pressure hydrocephalus. Congenital and acquired. I think it was okay now when you were mentioning now about, we were talking about etiologies, you mentioned now congenital and acquired. Also, when like you are talking about CT scan, on CT scan, how to recognize hydrocephalus, since we have medical students, small things, how to see if there's hydrocephalus, like measure the Evans index, okay, how to measure the temporal horns of lateral ventricles for you to diagnose hydrocephalus. So you should also mention those small things. And also, you said neurotube defect leads to Chiari. It's in the Chiari malformation where you get those things. And also, you said myelomeningocele causes enlarged ventricles. It's not the myelomeningocele which is causing hydrocephalus actually, because it's in the syndrome called Chiari malformation. It's that Chiari because you have downward displacement of cerebellar tonsils, which is now obstructing the flow of CSF. Then you get hydrocephalus. So in that syndrome, every child with hydrocephalus, you have to check if there is a myelomeningocele, spina bifida, and if there's club foot, then you talk about that syndrome called Chiari 2 malformation. So it's not the myelomeningocele which is causing hydrocephalus. So also you mentioned there are two types of Chiari malformation. There are not only two, there are many. There are many. Actually, they are not talking about Chiari 0, Chiari 1, Chiari 1.5, Chiari 2, 3, 4, Chiari 4. So there are many. There are not only two. And another thing I wanted to mention, it was about meningitis. Of course, it's an infection. Usually you get exudative, whatever, at the base of the skull. You get healing by fibrosis on the arachnoid granulations, which is reducing the reabsorption of CSF. You get infection. And so those are just small things I just picked up, maybe for future. And it's a huge topic. Since we have medical students, if we can share, like, you talk about physiology of CSF, physiology or causes of hydrocephalus, and treatment, just one day about treatment, it would be okay, instead of getting everything the same day. It's a huge topic. And also, make sure that every time you are presenting, you should also add your references so people can see where you got the information from. So we didn't see your references. Otherwise, well done, and we are encouraging you. Thank you.
Thanks, Dr. Kabulo.
Yes, thank you, Mr. Kabulo. All you say it is right, and The goals of this presentation, it is to highlight and done summary about hydrocephalus, because I can talk about all and go in about all details here. And I talk about physiology. I talk about that when I start my presentation. And you are right, we don't have just two types of Chiari malformation, like you said, I agree. But the common, I talk about the commonly type who give hydrocephalus, and it is the types 1 and 2. And like you say, it is, you are right about myelomeningocele. Yes, I know it is the it is all this syndrome who called. I know what I understand what you said, and thank you for all your comments, and thank you.
Very good. I'd like to take this opportunity to introduce a couple of late-coming panelists. Jack, MD, could you please introduce yourself?
Yes, thank you. My name is Jackson Chiwaligo. I'm a medical doctor from Tanzania, working at the district hospital. I am a neurosurgical aspirant. Thank you.
Very good. Very good. We've had a few doctors from Tasmania. Dr. Kabulo, he's not in Tanzania. He's in Mozambique. Okay.
Zimbabwe.
I'm sorry, it's Zimbabwe. I'm sorry.
Yes.
I'm sorry. Okay, Yehundi Tessie, could you please introduce yourself?
Yeah, I'm Dr. Yehundi Tessie from Benin. I'm in radiology in Medical Hospital of Mohamed V of Rabat. Nice to take part of conference.
Very good. You're welcome to any of our conferences. And we have your emails, right, everyone? Because we usually send out emails of notices. Did you get an email from us this time? Or leave your email, please. Put it in the chat.
Okay.
Yeah, put it in the chat box. You see where the chat is at the bottom? Chat.
Okay.
Yeah, click on the chat and just leave a message for me, or an email.
Okay.
Or just get through me from Facebook. You're probably a friend of mine on Facebook, John Bennett, MD. So I'm also there. So you can find me. Any remarks, Marco, for Nourou?
Yeah, John. First of all, I want to congratulate with Nourou. Is a very good presentation. Obviously, in just one presentation, we cannot talk about all the cerebrospinal fluid physiology, because we know at this time more and more about physiology, that it cannot be reduced just by a very simple concept like obstructive and communicating hydrocephalus. We're knowing more and more about the cerebrospinal fluid circulation. And another thing I want to ask to Nourou, in your department, what's your procedure to diagnose normal pressure hydrocephalus? You perform tap test, or you perform something more elaborated?
Nourou, did you hear all that, Nourou? Hope we didn't lose him, because I can't answer the question.
Oh, no problem.
Nourou, did you hear that question? Nourou, did you? I see you on the screen there. You're not on. Whoop. I think we're just having a little. We'll get him. He'll come back, I'm sure. Nourou, are you there? Can you hear me? Okay, I unmuted you. Try to unmute you. I'm sorry, we're having a little technical. We'll get it though.
No problem.
Unmute. Go ahead, Nourou. Are you there? Unmute yourself. I'm trying from one area. Let me try another area. Okay, go ahead, Nourou. Go ahead. Nourou? Oh, I'm sorry. I think it may be bandwidth because of now we're losing the. Can you hear me, Nourou, at all? Well, we can go on. And any other comments or questions from the panel before we sign off? Well, I'd like to thank you.
I think my last comment, maybe we...
Go ahead, Dr. Wall.
Yes, in consideration what Dr. Marcos said. So we have huge topics, and this is like we are doing basic sciences in neurosurgery. So we can share a topic even in 3-4 presentations, then we discuss in details. Yeah, thank you.
Okay. I think Nourou got back in here, I think. Nourou, are you back? There he is. Okay, one sec. Okay, Nourou, can you hear? Just give us a second here. Unmute. I'm trying to unmute you from different spots, but not having success, Nourou. Well, okay, Nourou, I have to thank you very much, and we're going to sign off because we're just having too hard a time unmuting you. But we're learning this tech. We're getting better slowly but surely. And once again, thanks for all the panelists. We're having good turnouts. This is great. And I'll send you the copies of this broadcast will be on Facebook as well as Neurosurgical TV. Any ideas you guys have on using this platform for education in neurosurgery, let me know. They're fun, they're informative. You meet people from all over the world like this one, and they're of educational value, as you saw those 2 great presentations today. So we'll be signing off, and thank you very much.